My name is Leonard Hochstein. I'm a board-certified plastic surgeon who practices in Aventura, Florida. I've been in private practice now for approximately 10 years. Prior to that, I performed training in general surgery in Dallas and then advanced plastic surgery at University of Miami. In the course of the last 10 years in private practice, I've come to specialize in breast augmentation and certain facets of surgery of the breast. Breast augmentation is a procedure that's been around for many years, but only has really been refined to a true science in perhaps the last 10 or 15 years. During that course of that time, there have been tremendous advances in both implants that we are able to use now and the procedures that we use to place the implants. There are several keys to performing the proper breast augmentation, and these have evolved through the years. I personally have an experience now with over 6,000 breast augmentations, and this experience has led me into the proper method of placing the breast implants while achieving the best possible results, the best possible symmetry, and the best, most natural looking results. There are a few basics about breast augmentation that every patient should know. The first is the type of implant. There are two basic types of implants, saline and silicone. Saline implants have been around from essentially the beginning. Silicone implants have had an evolution where they began as perhaps a less than ideal implant. Those implants had a thinner shell and had a bleed rate. In other words, the silicone would slowly leak. And these were the implants that were used primarily prior to 1991, at which point the government placed a moratorium on the implants. It should be stressed that in 1991, the reason silicone breast implants were taken off of the market was not because they were ever found to be unsafe, not because they were ever linked to any disease process, but because the FDA deemed that they should be studied more in depth. Multiple studies, including studies by the FDA themselves, have conclusively shown that silicone breast implants are not linked, nor do they cause any kind of autoimmune disease, or any disease for that matter. It is because of these studies that silicone implants have now been allowed to be used in the general population with some very minimal criteria. It should be noted that these silicone implants are a new generation of implants completely different from the ones that were used prior to 1991. These silicone implants have a thicker shell and a cohesive silicone. What that means is that these implants do not have a bleed rate. No silicone is leaking. And to make the matter even better for the patients, the silicone itself is more of a semi-solid rather than a semi-liquid. These implants can be cut in half, held upside down, squeezed, and the silicone itself will still maintain the shape. This has turned into a much safer, much better product for breast augmentation. The reason that silicone implants have made such a resurgence is because of the way they look and they feel. Quite simply, there's no substitute for a silicone breast implant as far as the best possible feel and the best possible look. I'd like to take a few moments now to talk about breast implants and the differences between them. I'd like to begin with talking about this implant. This is a saline breast implant. There are a few features about this implant that make it different from a silicone implant. The shell itself, however, is identical. The difference between this shell and the shell of a silicone implant is this valve right here. This is how the saline implant is filled once it's inside the body. When the implant comes packaged, it's empty, which makes it easier to place through a smaller incision. Once the implant is placed into either the subglandular or the submuscular pocket, which we'll hit upon later, a valve is placed into this area of the implant, and then the implant is filled with salt water. The advantages of a saline breast implant is that because it has a smaller incision that's required for its placement, there are more options for access. This can be placed through a transaxillary or an armpit incision, through an areolar or by the nipple incision, through a lower fold incision, or a transumbilical or a belly button incision. Some of these options fade away when you talk about a silicone breast implant. The great disadvantage of the saline implant is the saline itself. It is not a good mimic for breast tissue, and it doesn't lead to the best feeling result. Quite simply, these are not as natural an implant. When you touch a saline implant, you're able to feel the edge much more prominently than with a silicone implant. That translates into something called rippling or wrinkling. The risk of rippling or wrinkling with a saline breast implant, when it's placed in the submuscular or under the muscle position, is roughly around 20%. The risk with a silicone implant is roughly around 1%. This is a silicone breast implant. It has an outer shell made of silicone similar to saline. The difference is there's no valve. This is a perfectly smooth implant. The great advantage to a silicone breast implant is the silicone itself. There's no other substance that we know of that can mimic the feel, the consistency of breast tissue. What that translates into is a breast that feels much more natural and an implant that is almost undetectable. The disadvantage to a silicone implant is that it comes pre-filled. Because it's pre-filled, the incision required for placement needs to be larger. That basically limits you to 2 incisions, either the perioreolar or by the nipple or the lower fold. If it's a very small implant, the armpit or transaxillary incision sometimes is a possibility. The transumbilical or belly button incision is no longer an option. Silicone breast implants come in 2 varieties, either smooth or textured. This is a smooth breast implant. Texturing is a process which is added to an implant after it's made. This is an example of a textured silicone breast implant that also happens to be a teardrop shape. It almost has a fuzzy consistency. What this is made to do is reduce the risk of contracture, and I find it to be very useful. The problem with the texturing is it makes the implant thicker, so it makes it more easily palpable and increases that risk of rippling or wrinkling that I'd mentioned before. I typically use smooth breast implants, and only in situations where there's a contracture history or a contracture present will I use a textured breast implant for that reason. The other option with the implant is the appearance. Is it a round implant or a teardrop implant? This is an example of a teardrop implant, which is essentially made to mimic the shape of a breast. The round implant, which is what I was demonstrating before, has a shape that is completely consistent whether you turn it any which way. I prefer the round implant for a couple of reasons. One is it tends to give the best defined cleavage and the most superior fullness, which is really what women are looking for. The teardrop implants have a tendency to shift, and believe me, there's nothing that looks worse than one that is turned sideways or upside down, and I have seen it. Once a choice has been made to use a silicone, round, smooth breast implant, there is another option for the plastic surgeon to give each patient the best possible result, and that is the profile of the implant. The implant come basically in 3 profiles, low, medium, and high, which are termed moderate, moderate plus, and high. How these implants vary, going from the low or the moderate to the high, the diameter becomes narrower and the projection of the implant becomes greater. I found the high profile implants to be extremely helpful in patients who have either very small rib cage or want to go with a fuller cup size as their ideal look. Here I have in front of me examples of the 3 types of silicone smooth breast implants. These are all 550 cc implants. The way they differ is in the profile, low, medium, and high. As you can see, as you start from here and you graduate towards the high profile, the diameter of the implant significantly decreases while the projection increases. What this means is in patients who have relatively small rib cage, or in those patients who prefer to go with a larger look, I'm able to use an implant that will not stick too far out of the chest and will create a much better appearance, a much better look. And this is something that's been lacking over the past years of breast implants. There's been a lot of talk recently about a gummy bear breast implant. This is the newest generation of implant, which is currently not available in the United States, but I wanted to show what this implant looks like, its advantages and its disadvantages. This is the newest generation silicone breast implant. The silicone implants come in two levels of cohesiveness. Level 1, which is the more traditional implant, and level 2, or a gummy bear implant. The difference between the two is a level 1 is still a semi-liquid silicone, whereas opposed to a level 2, which is more of a semi-solid. If you were to cut this implant in half, it would really have the consistency similar to a gummy bear. That's how they got their name. Originally, these were touted as being the next generation, the best implant available. Unfortunately, I've been a little disappointed with their performance. One of the disadvantages of the implant is it's relatively firm. What this means is that patients are limited to a fold at the lower fold of the breast. And the incision itself has to be significant, almost the entire width of the implant. I find that to be extremely objectionable. The other problem with these level 2 implants is they're very, very firm, and I do not believe have the consistency of a natural breast. I want to mention this because this is something that has received a lot of press lately, and I wanted to set the record straight as far as what these implants' advantages and disadvantages are. To be honest, I believe that in the future they will be useful for reconstructions, but for aesthetic and cosmetic reasons, I still believe the level 1 silicone to be the best. This choice of saline versus silicone is probably the most important choice for the patient to decide upon because it will set up the foundation for the result. As a bit of historical information, the number or percentage of silicone implants that I'm using in my practice has drastically changed over the last several years. Prior to the moratorium being lifted, where silicone implants were used only as part of an adjunct study, I would say only about a third of the implants that I placed were silicone. Since they've been open pretty much to anyone to use, I would say now approximately 95% of the implants that I use are silicone, with a very small percentage now of them being used as saline. Once the implant choice has been made, there are a few other options the patient should be aware of. The placement is probably critical. There are two places where a breast implant can be placed, either subglandular or on top of the muscle, or submuscular, which is below the muscle. I personally prefer to place the implants in a submuscular position, and there are several reasons why I do this. The first is that it's a more natural feel. Adding the muscle layer to cover the implant significantly changes how much of the implant you're able to feel. By having the muscle coverage, you're essentially unable to feel the edge of the implant at the top of the breast, in the cleavage area, and in the upper outer area. There are a few areas where the muscle essentially peters out, and this is in the lower aspect of the breast and the lower outer aspect of the breast. In these situations, even with the silicone implant, some feeling of the implant is possible, and that is one of the limitations that we have. If, however, the implant was placed in a subglandular or on top of the muscle, essentially the entire implant could be felt, especially in women who have very little breast tissue. The other problem that occurs is that the implants tend to develop a contracture much more frequently than in the case of a submuscular placement. What this means is that the skin almost adheres itself to the implant, and you get that very artificial ball on the chest appearance, which is absolutely horrific, and I think most of the pictures that women point out to is this is definitely not what I want. A few other problems that can occur when implants are placed on top of the muscle are bread loafing and bottoming out. What this means is that the implant itself can actually fall down along the breast on the chest, so it actually falls below the fold. This is a very terrible situation, in which case an implant is well below the position of the nipple, and the nipple is almost facing outward. A very, very poor cosmetic result. Bread loafing, or similarly called uniboob, is a situation where the implants are essentially touching in the midline. Again, a very terrible, horrible complication of breast implants. I had previously touched upon the possible incisions that could be used. Basically, none of these options are off the table, whether the implants are placed on top of or under the muscle. Unfortunately, things don't always go well for breast augmentation patients. And I've had the pleasure of treating some of these women who've had horrible, terrible results, things that they would have never expected to. There are several reasons why this occurs, and they are typically in one of several categories. One is an either incorrect size of breast implants or an asymmetry from one breast to the other. There are also problems with placement of the implants themselves or complications inherent to the implant. Let me first start with the most common one, and that is that patients who are dissatisfied with the size or asymmetry of their breast implants. This is probably the most common thing I see, and quite frankly, I believe it's just an inadequate amount of time spent between the surgeon and the patient, which is very unfortunate. In my practice, we take the decision of choice of implant size very seriously. There are three things we do to make sure that the patient is getting the look that they want. The first is looking through pictures of patients with whom I've performed breast augmentation, seeing what they start out as before and the type of implant that it took to get them to their after look. This can be very helpful. Another helpful method is having the patient bring in pictures, clothed or naked, because remember, I'm not trying to pick a cup size or decide a cup size for my patients. It's more of a look. And if I can see the look that is going to make them happiest, I'll know exactly what size implant I'll need to get there. And of course, the last option is actually trying on the implants. We have special bras and special shirts that our patients can wear to reapproximate as close as possible what the implants will look like on them. And we found that using these three methods essentially makes it almost impossible for the patient not to be satisfied with their final size. I think it is unfortunate that many surgeons don't take out the time that's necessary to be able to make this most important choice. I find it also particularly disturbing that some plastic surgeons are so arrogant as to decide the implant size for their patients. I think this is an absolutely horrible thing to do. When patients ask me my opinion, I basically tell them that I'm the last person they should be asking. Implant size is a very specific question, a very personal question that they need to really come up with an answer on their own. As the surgeon, it is my job to place the implants perfectly so they look natural, soft, and symmetric. But I rely on my patients to choose the size and the look that they want. The other issue that I see is asymmetry in size. I find that some surgeons use two different size implants when it's always not necessary to do so. I find that all women have some differences in breast shape and size. However, implants vary as well. When you make as small as a 25 cc change in the type of implant, the diameter changes and the projection changes as well. I find it's much better to shape the breast by removing some breast tissue to both improve the size difference and also the shape of the breast, and then use the same size implant. Only in rare situations where I feel that I'm unable to properly shape and reduce one breast to match it to the other will I use a different size implant. The next problem I'd like to talk about is placement problems. This is usually an occurrence when one implant is placed either higher or lower than the other, or further out from center than the other, or too close or even past center in some situations. Another problem occurs when the implant essentially moves into the armpit as the patient lays down. All of these problems are essentially an improper management of the pocket. To place a breast implant, a precise pocket must be made exactly where you want to have the implant sit. If the implant pocket is placed too high, simply you will have too much fullness at the top and the nipple that can potentially point downwards. If it's placed too low, the opposite can occur, where there's very little fullness at the top, a nipple that points upwards, and there's way too much fullness at the bottom of the breast, and sometimes what's called a double bubble deformity. A double bubble deformity is a situation where the implant is so low that the natural fold essentially rides up on the implant itself, where you have the fullness of the implant and then the fullness of the breast on top of it, hence the name. The other problem that occurs is when implants are put too far apart. And this is a horrible situation where you have a tremendous gap between the implants, which is something that no woman wants. And an extreme example of this is when the pocket is made so far, particularly in the outer aspects, that when a woman lays down, she essentially goes flat in the chest area and the implant rides into the armpit. The opposite of the situation is something where the implant is placed too close to center, sometimes past center, where the implants essentially touch. These are all terrible complications of breast implants, but they can all be fixed, and these are all situations I've seen many times and have had the pleasure of fixing. And the reason this is such a pleasure is because typically when women come to see me, they've been operated on 2-3 times and they feel depressed. This is the last thing that they wanted. But by being able to correct this problem and giving them the breast that they had hoped for originally, it's the most satisfying part of what I do. I manipulate the pocket in these situations. And this is a combination of both pocket opening and closing. Opening the pocket where I want to increase the fullness and closing the pocket where it shouldn't be. In the situation of a double bubble or an implant that's fallen out, I place permanent stitches, and many of them, along the lower border and the outer border of the implant pocket. What this does is it fixes the implant back in a position where it should be, where it always should have been. The last need for a revisional surgery is an inherent complication of the implant itself. Most commonly contracture or possibly infection or bleeding. Infection and bleeding is a very rare occurrence now, and it can be treated simply by removing the implant temporarily in the case of infection, allowing the infection to settle and resolve, and then replacing the implant. Although it relies on a great deal of patience from the patient itself, the results are essentially identical to what would have been had the infection never occurred. A risk of bleeding or hematoma. This is something that typically happens within the first 24 hours of implant placement, and again, a very rare occurrence. In this situation, it's important to go back in, remove the blood, and find out where the bleeding is from, and then reinserting the implant at that same time. Again, the results of this operation also essentially are no different from had this problem never occurred. The last complication, and probably the most dreaded one because it happens with relatively higher frequency, is that of a contracture. Contractures occur for no reason. We don't know why they occur, but we do know that certain things influence them. We know that putting the implant under the muscle reduces the risk of contracture. We also know that using a textured implant reduces the risk of contracture. What occurs in this situation is a squeezing of the implant capsule. Simply put, whenever a foreign body, whether it be a breast implant, a pacemaker, is put inside a human body, the body forms a shell around itself, or a capsule. This is a normal occurrence, and we want this to happen. It's essentially a walling off process. In a very small percentage, and I should point out that in my practice, and now over 6,000 breast implants, I've only had 24 contractures. This capsule essentially squeezes itself, and this creates a very firm, misshapen, unnatural, sometimes painful breast. Once this occurs, I found the only treatment is surgical. What I've done in those situations, I've gone back in, removed the shell or the capsule completely, and replaced the implant with a textured implant. And so far I've had a 100% success rate. In treating patients who have come to me from other areas, I find the most common reason for contracture is an implant that is placed on top of the muscle. In those situations, I do not use a textured implant. I still prefer to use a smooth implant. But simply by placing the implant from on top to under the muscle, again, I've had a 100% success rate and avoided this contracture problem. Breast lifting or breast reduction surgery is an operation that is often used by itself or in conjunction with breast implants. There are several options for lifting a breast. One option, which is called a minimal scar lift or donut lift or mastopexy, is a situation where an incision is made around the areola and a second concentric circle is made outside of this. The skin in between those areas is removed and tightened in a purse string fashion. What this does is it lifts the nipple and tightens the skin of the breast. This is a very useful operation for patients whose nipple is still at the level of their fold or slightly above. And it's useful in situations where the nipple needs to move up 1.5 centimeters to 2 centimeters or close to an inch. The next option for lifting is what's called a lollipop lift. In this situation, the incision is made around the areola and straight down to the fold of the breast. This is a slightly greater lift and allows the nipple to move up approximately 2 to 3 centimeters. The last type of lift, and this is considered the major lift, is the Wise pattern lift or the anchor lift. In this situation, the incision goes around the areola towards the bottom central part of the breast and along the base of the breast or along the fold of the breast. This allows the nipple to move up as far as it needs to go and also allows the surgeon the most freedom in reshaping of the breast to give the desired look that's necessary. This can be done in conjunction with an implant to improve the shape and the size of the breast. In situations where the minimal scar lift is used, the implant can be used to gain fullness, to gain more cleavage. In the other situations, the implant can be used to completely transform the breast. I find that a lot of women who have had significant droopiness or ptosis, whether it be through weight loss, through childbirth, or simply being born in such a state with large breasts, that a lift simply reduces their breasts too much. The problem here is that most of the breast tissue ends up being at the lower aspect of the breast, and simply tightening the skin won't do it because the weight of the breast tissue will simply stretch the skin back out. To properly do the operation, this breast tissue needs to be removed. Once it is removed, women find that the resultant cup size is just too small for their taste. And in this situation, a breast implant can be used to get them back to the size that they want, and what's better, improve the shape of the breast, giving them much more cleavage definition, as well as fullness at the top of the breast. It is also a very common occurrence for women who have mastopexy breast lift as a result of childbirth to do this at the same time as an abdominoplasty or a tummy tuck procedure. This is a very common combination in my practice, and one that I found to be tremendous in getting women back to the bodies that they had prior to childbirth. I have some very strong opinions about breast surgery and breast implant surgery. These opinions have not come about overnight or over the course of a few breast operations. It has taken me over 6,000 breast augmentation procedures to come to the point where I am now. And I would like to say that the surgeon that I am now is very far from the one I was 10 years ago. This experience is something I would like to use for you to get you the best results possible. Picking your surgeon is probably the single most important factor in getting the results you want. I would like to use my experience in the field of breast surgery and breast implant surgery to get you the result that you're looking for.
All right, we're good.
I perform surgery in a Quad A certified, state-of-the-art facility. We also make sure that you are given the best anesthesia care. That is administered by Dr. Vladimir Lifschultz. He is a board-certified anesthesiologist who's been with me now for over 3 years and has done the anesthesia on every single one of my patients with both great success and happiness on my patient's part. We are also careful to cater to all of your needs both before and after surgery. This is an operation that we do a great deal of. We know exactly what to do, and we know exactly how our patients deserve and should be treated. This is a team, and this team's goal is to make this experience as pleasant as possible. I know that surgery can be an intimidating experience. However, everybody on my staff knows what to do to make this as pleasant an experience as possible. And we will go out of our way and do anything we possibly can to make sure that every patient is happy with their experience.